Welcome to Nursing 141, which is Farm 2. My name is Greg Karagesian. I'm a doctor in Canada, and I've been doing voiceovers for Ameritech College, in particular Pathophysiology 2 and Farm 2. So let's start this course. So the first slide here, I won't say too much about this first introductory slide. This is just showing you the different parts of the body that can be donated. There's some that are donated much more commonly than others. For example, the cornea, very common part of the body that can be easily transplanted to someone else. Especially since the cornea does not have a blood supply, so it's very simple to transplant a patient's corneas to someone else who needs them, that has damaged, scarred corneas, and they're unable to see. Cardiac transplants, very common. Now we get into organs that obviously need immunosuppression, meaning you need to turn down the immune system of the person receiving these organs so that your own body or their own body doesn't attack the foreign organ, whether it's a heart, or kidney. Kidney transplants are extremely common. So when you get a kidney transplant, you get a kidney, one kidney, and they can last a very long time if taken care of. And when you say taken care of, by avoiding toxins such as cigarette smoking, high blood pressure going to the kidneys, and taking your immunosuppressants regularly, whether it's for your heart or your kidneys. So heart and kidneys are both very common transplanted organs. And by the way, when your kidneys are transplanted, they're actually the new kidney is put in your lower abdomen. So in the left or the right lower abdomen. They don't transplant the kidneys where the original kidneys used to be. Intestines would be a very uncommon transplantation, so I won't mention too much here. Tissue transplants, so they may use skin cultures, they may use skin transplants from a patient that has died. Pancreatic transplants, not very common yet, unfortunately. I think they will gradually increase over time, but they're not very common. Liver transplants can be extremely effective in people with end-stage liver disease or cirrhosis that will not survive without a liver transplant. And lung transplants for people with chronic lung diseases that are waiting on the transplant list to receive new lungs can be extremely effective as well. Remember, all of these need immunosuppressant medications, except for the cornea. And it's because it just doesn't have blood supply, so your body really can't attack a corneal transplant since the blood doesn't get to it. Okay. So I'm going to skip to the slides now that are related to pharmacology information. So just I want you to keep a couple of things in mind. So the first thing is in pharmacology, the less, and I know this won't make sense, but the less you memorize, the easier it is for you. The more you understand, uh, the easier it is. If you understand processes, for example, some pathophysiology, then you'll understand what the drugs are doing to the body. So it's very difficult to memorize pharmacology as a whole. There's definitely parts that take some memorization, and as we go through this, I'll mention some things that it's likely worth memorizing, or it's likely worth understanding this a bit more so that you can retain it, not only for exams, but for later in life as well. These first few modules, especially the chemotherapy module, has a lot of information in it, a lot of different types of drugs, different cancers, and just try and keep a big picture. I don't think the expectation is for you to memorize each individual cancer and each drug that is in a protocol for a specific cancer. That's impossible. Even cancer wards, there's protocols in binders um, that are used for treating a different assortment of cancers. So try and take a big picture approach so that when you get questions about cancer in general or chemotherapy agents, you'll have a much better understanding of the topic, so the questions will be easier to answer. And as I'm going over these voiceovers or these modules, I will keep in mind that you do have exams to pass. So I will cover topics that are pertinent to your exam material, and also for later on um, for ATI and for NCLEX. Okay, so let's start. We're going to be talking about the immune system of the body. Um, And the immune system of anyone's body is on 24 hours a day, right? It's constantly protecting you from invasion, whether it's from bacteria that live in your colon, or from an infection that's developed in your lung, such as pneumonia, from a viral infection, or even the constant potential for cells in your body to become cancerous. And your immune system immediately recognizes these cells as foreign and destroys them. We don't actually know how many cells mutate in a day. So because you have a lot of dividing of cells, some of them mutate. And without your immune system, some of them would go on to become cancerous. And it's because of the different parts of your immune system that not only invading infections, whether they're bacterial, viral, or fungal, but also cancerous cells that have potential to grow are have constant surveillance by your immune system. So on this side, we're looking at non-specific body defenses, meaning, you know what, it's not for any one particular virus or any one particular bacteria or any one particular cell that has become cancerous. It's just the general defense of anything that tries to get into the body. So there's the physical barrier of your skin, which forms a complete layer that gives you a lot of protection, right? It gives the underlying tissues a lot of protection from invasion. Your skin, I mean, if you swabbed your skin, you would see that there's all kinds of different bacteria on your skin, in your mouth, but it doesn't invade the body, and partly because the skin has a natural immunity to stopping infections to penetrate them. And that's why when someone punctures their skin or punctures the sole of their foot, they're at risk for introducing an infection, whether it's a local infection like a cellulitis, which is a local bacterial infection, or a bloodstream infection like bacteremia. The bacteria have gotten into the blood supply and made the person much sicker. So intact skin is very important as a protection. Mucous membranes. Well, the mucous membranes are your eyes, your mouth, your respiratory system, your gastrointestinal system, and they all have ways of protecting the person from acquiring infection, right? So in your lungs, you have little tiny hairs called cilia that are constantly moving antigens or infections or pollution up out of the lungs. The gastrointestinal system has acid in the stomach that when you're eating something, or if you touch your hand to your mouth and you ingest a virus or bacteria, there's a very good chance that the stomach acid will destroy it. Okay, so those are just physical barriers from trying to get into the body. Cellular barriers. Well, you have what are called phagocytes, and these are cells that just will attack foreign antigens. So an antigen is something that's foreign to the body, to the human being. So these cells will recognize the antigen as being foreign, will invade them and ingest them. And these phagocytes can be all over. They're within your lungs. They're within the gastrointestinal system. They're in many organs, and they're just surveying, looking for any foreign antigens to destroy. Okay. Natural killer cells. So these are cells in the body that are looking to attack cells that are infected with viruses or cancerous cells. Okay, so these cells will directly attack cells that they're seeing as virally infected, or cancerous cells within the body themselves. The other ones are a lot of them are molecules in your body that are produced to activate the immune system. So complement is it's a system in the body. It's a cascade of molecules that are produced called complement. Just like there's a cascade of coagulation factors to help you clot blood, there's a cascade in your system, in your body, called complement. And when this system is stimulated, it promotes inflammation to the area. So, for example, say you have a pneumonia. Your body will be releasing cells within your body will release complement factors. And what they'll do is they will create inflammation at the area, and that inflammation in the setting of these molecules of the complement system will bring cells, bring in your cells to attack the infection, such as pneumonia. So it attracts cells and it creates a lot of inflammation. And inflammation can be good because inflammation means that you are bringing your own cells to the area to attack the foreign substance, whether it's any form of antigen. Fever. So your body responds to infections with a fever. And we know that fever can be a good thing. It can, well, not only does it warn you that there is a potential infection occurring in your body, but many processes in your body, in the immune system, actually work better at a slightly higher temperature. So it activates certain enzymes that are needed in the immune system. And also fever can slow down certain infections from progressing too quickly. So fever isn't necessarily a bad thing. We often like to bring it down with medications such as acetaminophen or ibuprofen because people feel better when we do that. But fever in itself is a warning system and is also activating certain enzymes in the body. Inflammation, we mentioned, limits the spread of infection because you're surrounding it with your own inflammatory cells. And also it's bringing in a lot of cells to heal the area that's been damaged. Interferons. So interferons are proteins that are produced by certain cells in your body when they are infected with viruses. So when you think of interferons, think of viral infections that are invading the body, and your cells are now making interferons, okay? And they're proteins. And what they do is they warn uninfected cells that there's a virus in the body, okay? And they also stimulate what's called phagocytosis. So they stimulate the phagocytes to ingest to attack and ingest the viruses and destroy them. Okay, so and that's why interferons are now made as drugs, because we discover them in the body and they activate the immune system in the setting of viruses, and now we turn them into certain drugs. Okay, so bone marrow suppression. This is a term that it's basically what it is. The bone marrow bone marrow production has been suppressed, and it's either from a disease or it's from drugs that we use, such as chemotherapy drugs commonly do this. And there's 3 cell lines in your bone marrow that are produced: red blood cells, white blood cells, and platelets. So if you think of these 3 cell lines, if the bone marrow gets injured either by some kind of an infection or a cancer, it will likely affect all 3 cell lines. Just like chemotherapy agents for cancer typically hit all 3 cell lines. So you become anemic. And we'll talk about anemia later It's low red blood cells, right? So your ability to carry oxygen has been reduced. You become neutropenic, or leukopenic. Leukopenic is just a general term for low white blood cells. So leuco is white, penic is low white blood cells. A section of the white blood cells are called neutrophils. So a portion of them are neutrophils, and they're very important. They are the ones that fight bacterial infections, and they're the ones that we get very concerned about when they're low. So you can become neutropenic, and we'll talk about that a bit later. And then, of course, if the platelets are low, and normally your platelets are 150,000 or greater. So as your platelets get lower and lower and lower, you are at higher and higher risk of bleeding, because platelets are the first part of forming a platelet plug at a bleeding site. Okay. So in terms of management, we definitely have to monitor labs, typically a CBC, to watch out for the cell lines from the bone marrow, and also teaching the patient about the symptoms of anemia and the symptoms and what to avoid of an infection, and very important things to do when you're on chemotherapy agents to avoid getting an infection. Okay. So the labs, I'll leave that to you. These are very typical lab results, normal lab results. White blood cell count, total white blood cell count 5 to 10,000. Hemoglobin is slightly higher in males, 14 to 18 versus females 12 to 16. And again, your platelets are typically above 150,000. Bleeding precautions, well, that comes back to the platelet issue. And transfusions, so typically there's 2 items we can transfuse if we needed to. We can transfuse red blood cells, so that comes in packed red blood cell units, PRBC, and we can infuse red blood cells for someone who's anemic, and we can also transfuse platelets. So platelets come in packages when the platelets become critically low, and typically that's at a very low platelet count, 20,000 or below, 10,000 or below. So it's not someone who has a platelet count of 100,000 that we're that worried about. It's the patients that are very low with platelet counts of 10 to 20,000. Okay, so let's talk a bit about patient precautions in the setting of potentially acquiring an infection. And who's at risk for potentially acquiring a serious infection? It's patients that are immunosuppressed. So if someone is being treated for cancer with chemotherapy agents, those chemotherapy agents aren't just going to destroy the cancer. They're going to destroy and affect the bone marrow of the patient. So they will typically and very often become anemic, leukopenic, low white blood cells, which is definitely part of your immune system, and thrombocytopenic, low platelets. So we give a lot of advice to patients that are on immunosuppressant drugs, and that also goes for patients that are taking immunosuppressants after a transplant. So whether you've had a liver transplant, a kidney transplant, and you're on lifelong immunosuppressants, that is purposely knocking down your immune system to stop it from attacking a foreign organ that um, you've acquired to live, such as a kidney or a liver or a heart. So think of drugs that are chemotherapy agents for cancer or any immunosuppressant drugs that we use purposely to lower the immune system. So the first one here is fevers. So anyone who's on these types of drugs and develop a fever, that's a concern because that can be an indication of a life-threatening infection when you're immunosuppressed. Hypotension, low blood pressure, that can be an indication that the bacteria has made it into the bloodstream and is causing you to be hypotensive. So definitely those are things that you report immediately. New symptoms of infections, such as a wound on your skin that's red or discharge or tender. A new cough with sputum would be a concern. You can definitely get thrush in your mouth. That's white. So white patches in your mouth would be candidiasis. Candida is a yeast infection, and typically you get it in your mouth, and we call it thrush. Or women can get it as a vaginal infection, and it's usually white cottage cheese type of discharge. Symptoms are usually itchy vaginal discharge. And lastly, the next one, the itchy blister. That one's referring to herpes zoster or shingles. So people that are immunosuppressed are more at risk for getting shingles on their skin. But in general, just think of any infectious type symptom, and that should be reported when you're on these types of drugs. Frequent hand washing, avoiding any cracking or peeling or open skin is crucial. So using moisturizers, making sure that you don't have cracked, dry skin, very important. Avoiding crowds, such as malls, crowded family get-togethers, people with colds or infections, avoiding them. People with young children. Why do we suggest that? Young children often have viral infections, and you certainly don't want to get one while you're immunosuppressed, or not only children, but anyone that's not feeling well. Cooking food thoroughly, okay? So whether it's meats, anything that has the potential to introduce bacteria into your system needs to be cooked very well and washed very well. And then thoroughly cleaning up the area afterwards as well. Avoid consuming raw foods. So raw foods can sometimes be very healthy for you. In this setting, raw foods could put you at risk for eating something that has bacteria or virus within it. Okay. Regular follow-ups to the lab to check your hemoglobin count, your white blood cells, your platelets. Avoiding pregnancy. Well, these drugs are often toxic to a pregnancy, so avoidance of pregnancy would be extremely important. Avoiding cleaning up cat litter, any kind of waste product. They obviously have a lot of different types of bacteria, parasites within them, so you would avoid that. Gardening would be something to avoid, and as we mentioned before, any kind of skin injury would be important to avoid as well. Okay, so this slide on immunostimulants and immunosuppressants. So on the left are drugs, and at the bottom of vaccines that activate the immune system. So we discovered interferons and interleukins are made naturally within the body, and then they are now produced in labs to activate the immune system when we want to further activate it. And so interferons and interleukins are produced for certain conditions now. Colony stimulating factors. So there's if someone's on a chemotherapy agent, um, we may want to purposely increase their white blood cell count. And there's a drug such as this one called filgrastim, Neupogen, filgrastim. It's easier to say Neupogen. That stimulates the bone marrow to make white blood cells. So that's a type of an immunostimulant, right? So anything on the left here is trying to stimulate. We are purposely trying to stimulate the immune system to fight some kind of infection, and we do that with vaccines too. We give someone an injection of a vaccine, whether it's for Hep B, or for tetanus or pertussis, and we're injecting a foreign substance into a patient, and that's going to produce an immune response, an immunostimulant response from the injection of the vaccine. On the other side are the immunosuppressants. So we want to purposely knock down someone's immune system. And we do that for a number of reasons. For a transplant, such as in the first one there, calcineurin inhibitors, such as cyclosporin. That's a very common agent after you've had a transplant to stop the immune system from attacking the new organ you've received. Or in a very general sense, cytotoxic drugs and antimetabolites, those are just fancy words for saying chemotherapy drugs to attack cancer. So while we're attacking the cancer with these drugs, we're also attacking our own bodies, the patient's body, and stopping their cells from dividing as well. Because that's how these drugs work, right? They stop the cancer from dividing, but they also stop your cells from dividing. And a bone marrow is one of the most rapidly dividing cells in the body. So they are definitely impacted by immunosuppressants. So a common one there would be azathioprine. We'll come back to it. That's a common chemotherapy drug. And then there's antibodies. So think of the antibody. So we can produce antibodies in the lab now. And look at the last part of these painful words, basiliximab. So MAB, monoclonal antibody, MAB. So these are like sniper cells or sniper chemicals that we can make now that attack a specific part of the immune system to stop it from working. So for example, if we know a certain part of the immune system needs to be slowed down in order for you to have a foreign kidney or a foreign liver, then we can produce an antibody that attacks that part of the immune system to slow it down. And that's what monoclonal antibodies are. Okay, so all they do is they attack a part of the immune system to slow it down, and we'll come back to that. But they're definitely immunosuppressants. Don't confuse that with the antibodies that you make in the body to attack infections. Corticosteroids. So steroids are just a general immunosuppressant. Steroid drugs, whether it's oral, such as prednisone, or whether it's IV, such as methylprednisolone, they inhibit the immune system. They're anti-inflammatories as well, so they're very effective drugs that we use for a number of conditions, including stopping the immune system from causing rejection of a new organ. They slow down the immune system. Okay, so people that are on steroids are immunosuppressed. So if you're receiving corticosteroids because of a certain cancer, or you're on prednisone because of some kind of inflammatory condition you have, such as Crohn's disease or asthma, and you have to be on corticosteroids, you're immunosuppressed. Okay? So if you see that someone's on a corticosteroid, you have to think, oh, this person's at risk for infection. Okay, so let's talk about interferon a bit. So remember, interferon is naturally made in the body from a cell that's been infected with a virus, and it releases interferon to communicate or to interfere with the viral infection, right? So interferon is a chemical that's released by infected cells to warn other cells of the body that there's been an infection by a virus, so that upregulation of the immune system is needed to attack this virus. Okay, so now this has been turned into a drug, so that we can upregulate the immune system with an injection. An interferon is usually given as an injection, and we can use it in certain types of cancers. Lymphoma is a cancer of the lymphatic system, the lymph nodes. So I would think of lymphoma as a type of cancer. And then, of course, viral infections as well. We use interferon. So let's use some specific examples where, this might make a bit more sense. So patients with multiple sclerosis, we've never really known what multiple sclerosis is from. One of the theories is that it's from a viral infection, and people with multiple sclerosis, when they have a flare-up, they receive interferon shots. And this is to activate the immune system and potentially reduce the flare-up of their MS. In terms of viral infections, hepatitis B, hepatitis C, when people had infections of their liver with these viruses, interferon could be used as an injection to treat their hepatitis secondary to a virus. And as well, interferon is sometimes used in combination with chemotherapy drugs to treat certain cancers. Okay, because it upregulates your immune system, and it puts it on alert and on the attack to attack viruses or cancer cells. Okay, so how do they work? So these are just little proteins. Again, we have it as a drug that communicate between immune cells and activate the immune system to fight viruses and certain cancers. What's the most common adverse effect? So always go for the strange adverse effects. There's no sense in memorizing what causes nausea and vomiting and diarrhea, because everything does. So that'll be a waste of time. Go for the strange adverse effects. So look at the first one, flu-like illness. That is strange. When you get an injection of interferon, you get a flu-like illness of fevers and aches and myalgias and sore muscles. And well, it makes sense that you get that because interferon naturally in the body are, those are the symptoms it creates when you have a viral infection. You're achy, you have a fever, you feel lousy. Well, that's what happens when you get an interferon injection. Okay. It can cause some bone marrow suppression. I would definitely remember the first adverse effect because that is a strange one. You're going to come across many things that cause bone marrow suppression, and I'll tell you when it's more important to remember that. But flu-like illness is the #1 symptom with an interferon shot. So what nursing responsibilities would you want to tell the client? Well, definitely that they're going to feel like they've been given an injection of a cold, right? So by getting this injection, you've basically upregulated their immune system, and your body now thinks it's fighting a virus, okay? Because that's what interferon is typically released in, a viral infection. So it's going to feel like they have a viral infection, okay? And they can definitely use acetaminophen if they have a low-grade fever or if they have achy muscles. And interferon, as mentioned, is typically given as an IM shot or IV, but never orally. And why never orally? Well, it's a protein. So if you eat a protein, your gastrointestinal tract just breaks it down. So it's never given orally. The main thing to check on with these people is just how they're feeling. Do they feel miserable because we basically given them the equivalent of a flu-like, flu-like symptoms, and also to check their CBC, complete blood count, to make sure that we haven't caused them to be low on blood or like bone marrow suppression symptoms. Okay, so now we're looking at a prototype of an interleukin. So interleukins, so before we start interleukins, know the term cytokine. So a cytokine is basically a chemical or a molecule that is secreted by cells of the immune system. So the two that we're talking about are interferons and interleukins. Those are both cytokines. And they both in different ways communicate with different branches of the immune system. So interleukins communicate between white blood cells. They regulate the activity, the level of activity of white blood cells, in particular the T cells, but also the B cells as well. These particular drugs are much more involved in the treatment of certain cancers. And again, I don't think you need to memorize which cancer interleukins affect, but you can see at the top renal cancers, malignant melanoma of the skin, certain lymphomas. But just know that interleukin is a type of cytokine that we can inject to activate the immune system in certain cancers. So if we're activating the immune system, look at the main adverse effect again, flu-like illness, okay? Rashes, we're not going to get into. Any drug can give you rashes. There are some particular drugs where rashes become the #1 side effect, but not for interleukins. So the two here that really stand out, and they're underlined, are flu-like illness and what's called capillary leak syndrome. So capillary leak syndrome can occur with a number of different types of drugs and different illness. The perfect example of a condition where you have leaky capillaries all throughout your body is sepsis. So you have bacteria in your bloodstream, you have an infection that's coursing through your blood, and your capillaries, your blood vessels, have become extremely vasodilated and leaky, and they're leaking fluid into the interstitial fluid out of your blood vessels. Well, there's certain drugs that can do that, and interleukin is one of them. And so you can imagine this can be very serious. If we give someone interleukin, like as an injection for a cancer, and we make their capillaries very leaky, well, that's going to cause a lot of fluid to shift from the intravascular space to the interstitial space of the body. This will cause them to have very low blood pressures. They're leaking proteins out of their capillaries, so they can have low serum albumin, which is the main protein in your bloodstream. They'll have edema, swelling all throughout the tissues of their arms and legs. So it can be a serious side effect from interleukins. So the other ones I would not spend as much time on. I would think of the flu-like illness and the capillary leak syndrome. The other ones are very non-specific, reduced appetite, a bit of diarrhea. That's impossible to remember once you start to add up all the drugs. So very difficult to memorize non-specific symptoms or signs. Nursing responsibilities. So again, give an IV, sub-Q, not PO. This is a protein. It'll be broken down. One of the other side effects, just to give some consideration to, is that interleukin as an injection, as a drug that we use it for cancers, can give you low platelets. Okay, so remember, interferons could lower your bone, could give you some bone marrow suppression. Well, so can interleukins, and low platelets from IL-2 or interleukins in general. You're going to suggest to the patient to avoid aspirin products. Anyone who has the potential to have low platelets, or we already see that they have low platelets, we tell them to not use aspirin products because aspirin binds to platelets and makes them inactive. Avoiding cutting themselves, such as in shaving or in brushing their teeth. That's good advice to give someone who has the potential to have low platelets. Okay, and again, we would monitor someone who's taking this regularly to check on their bone marrow status with a CBC, and that also gives you a platelet count. Okay, so let's talk about some immunosuppressants. We just spoke about two immunostimulants, such as interferon and interleukins. Cyclosporin or tacrolimus, which is in the same group, are immunosuppressants. Okay, and cyclosporin is in the group of calcineurin inhibitors. I think this is just something you got to memorize. You can look into calcineurin and what it does, but just know that cyclosporin is a calcineurin inhibitor. So it's going to be used in conditions where we want to get the immune system to back off. Okay, so let's look at the conditions. So prevention of organ rejection, such as in kidney, heart, liver transplants. What about autoimmune diseases where we want to reduce the activity of the immune system because it's gone a bit haywire and it's attacking the own body. So conditions such as psoriasis, rheumatoid arthritis, Crohn's disease, ulcerative colitis. These are autoimmune diseases where the immune system has gone a bit overboard, and now we're using an immunosuppressant such as cyclosporin to reduce the attack. Okay. So what does it do? This calcineurin inhibitor group, it diminishes the activity of T cells and cytokines, interferons and interleukins, and thereby suppressing the immune system. Okay, so turning down the T cells, reducing cytokines in the body, that will lower the immune system. Now, how can we give cyclosporin? So cyclosporin comes orally, which is great because people need to take these drugs at home. And it can also be given as an injection, but that's not as useful. These drugs are used by many people as an immunosuppressant, so the fact that it's oral is a big benefit. What about the adverse effects? Well, if you're turning off the immune system, or if you're turning it down, I should say, then you're basically reducing the surveillance of the body to potentially catch a cancerous cell from forming. So over the long term, if you're using cyclosporin, say for example a kidney transplantation that was required, you are at long-term risk of getting a cancer or a lymphoma because your immune system has been turned down. So if your immune system is fully functional, it can catch cancers and destroy them right at the beginning. If it's been suppressed by something like cyclosporin or tacrolimus, then the chances of you forming a cancer over years and years of using these drugs is increased. Okay? You also have an increased chance of getting an infection of any type when you're on these drugs because they're immunosuppressants. So all that information sheet on what to report to your healthcare provider or to notify the nurse, those would all apply to these drugs. The other effects are listed here. One of them to notice, cyclosporin can give you high blood pressure, which is a bit difficult because this is used for kidney transplants to avoid renal transplant rejection of a kidney transplant. Sorry. So it gives you high blood pressure that can harm the kidney. So high blood pressure needs to be monitored with someone on cyclosporin. It can cause some gum swelling. There's a couple of drugs that over time you're going to associate with gum swelling. Cyclosporin is one, and there's another one we'll talk about later in the seizure. Or maybe that was in the pharmacology one. Phenytoin gives you gum swelling as well. So contraindications to using cyclosporin, well, it would really be, uncontrolled hypertension, because this will aggravate hypertension, and also pregnancy. Remember, this is an immunosuppressant drug. It can result in preterm labor. It's not known to cause birth defects, but it can cause preterm labor. So it's avoided in pregnancy. So we definitely monitor serum cyclosporin levels just to make sure that they don't get too high, which will aggravate which will make the side effects worse, right? The hypertension will be even more difficult to control. And again, it can be given PO or IV. Okay, so let's talk about another immunosuppressant that's relatively common in a variety of, for treating a variety of diseases. So azathioprine. So azathioprine, you can think of azathioprine and mercaptopurine as basically the same drug. Azathioprine is what you would take as a pill, and the body will convert it to mercaptopurine. Okay, methotrexate is on there, but that's just another example of an immunosuppressant. Okay, but azathioprine and mercaptopurine you can see is the same drug. So what do we use immunosuppressants for? Well, it's going to be the same thing. It's for prevention of rejection in kidney or liver transplant, and then a huge assortment of autoimmune diseases. We could use azathioprine in to reduce the autoimmune attack on the body from itself. So conditions like Crohn's disease, which is an inflammatory condition of the bowel. Ulcerative colitis is another one of the bowel. It can be used in rheumatoid arthritis, systemic lupus, all conditions that are autoimmune. And how does this drug work? Well, it works by inhibiting RNA and DNA synthesis. So it's a bit of a misprint there. Inhibits RNA synthesis causing DNA damage. So it basically inhibits cell division by reducing DNA and RNA synthesis. Okay, so in autoimmune diseases, well, it's gonna have that impact on your white blood cells, and that will lower your white blood cell count and make you immunosuppressed. But that's going to improve autoimmune diseases, and the same thing in avoiding of transplant rejection, right? You're weakening the white blood cells by stopping them from dividing, and that's immunosuppressing you. Okay, so what's the main? So remember, taking an immunosuppressant over the long term, what's a potential long-term complication? Well, it's the development of a cancer because you were taking this drug, right? Because your immunity has been down for so long that you've developed a cancer because your immune system wasn't on high alert the whole time. So what's the main effect of azathioprine, or the main adverse effect, sorry? So hepatitis, liver toxicity. So if you think azathioprine, it's hard on the liver, so it's going to give you it's going to give you elevated liver enzymes in your bloodstream. It could make you turn yellow. It can make you feel. You'll lose your appetite. It can give you dark urine because you're spilling bilirubin from the liver damage into your urine. So liver toxicity, and we definitely monitor azathioprine. We check the liver, and bone marrow suppression. Right, so it stops rapidly dividing cells, and bone marrow is one part of your body that's rapidly dividing. So all the cell lines in the bone marrow are affected. The red cell line, the white cell line, and the platelets. Vomiting, fatigue. Well, fatigue is going to be from anemia, and then of course the increased risk of future cancer we spoke about. Contraindications, you would not use this drug in someone who already has liver injury or damage. So what are the responsibilities when someone is receiving this? Well, definitely to advise them on the risk of infection, the risk of long-term cancers, and frequent monitoring of CBC to make sure the bone marrow doesn't get too affected, and liver function tests as well. It also says avoiding immunizations. So we tend to avoid live, we'll come to the immunization section later, but we tend to avoid certain immunizations that are called live attenuated, meaning they've been kind of crippled by what we've done to them in terms of they can't cause active disease, but they're still live. And if someone's immunosuppressed, we avoid live vaccines. So let's talk about antibodies that are made in a lab that act as immunosuppressants. So, and again, what do we want to use immunosuppressants for? We can use immunosuppressants to stop your body from rejecting an organ. We can use immunosuppressants to turn off your body's immune system when it's attacking itself, autoimmune diseases. So, so this one, basiliximab, so MAB, it's a monoclonal antibody, is targeted like a sniper to the binding of interleukin to activated T cells. Well, that's going to knock down the immune system from working well, because now you've knocked down your T cells, and it's not going to attack transplanted tissue as easily. So a very common indication for this is kidney transplantation. Okay, adverse effects. Most of these are pretty generalized. Maybe the one to remember is the flu-like illness. Since it's messing with interleukins, it might be a bit easier to remember that particular adverse effect to basiliximab. This is given as an IV infusion, basiliximab, typically just before the renal transplant and afterwards. It's given as 2 IV doses. There can be infusion reactions, and I think that's all we need to go over for this particular drug. Okay, so this next drug, filgrastim or Neupogen. There's some other ones that are similar to it. You know, whenever a pharmaceutical company makes one drug, then other pharmaceutical companies want to get in on the action, and they make different drugs but have the same effect. So I think the prototype is really the one to know. And this drug we give because of the side effects that we caused from the first drug. So for example, we've given a chemotherapy drug that has knocked down the bone marrow of the patient significantly, making their neutrophils and their white blood cell count extremely low. And we'll use this drug, filgrastim, it's a white blood cell stimulating drug. It forces the bone marrow to produce white blood cells. So indications, it increases neutrophil production in the bone marrow. Okay. It enhances phagocytic and cytotoxic functions of the existing neutrophils. So basically this is stimulating the white blood cell, the neutrophil part of the white blood cells, to be released from the bone marrow because your neutrophil count is so low that you're at risk for serious infections. So the actions causes increased neutrophil production in the bone marrow, resulting in high neutrophil counts in the bloodstream. So with an injection of this drug, you can sometimes we'll do blood work on someone and we'll get a white blood cell count of 25, 30, 35,000. And it's because of this drug that has pushed out so many white blood cells from the bone marrow into the bloodstream. And because it's stimulated the bone marrow, what's the main side effect? Well, it gives you bone pain. So if you had an injection of this drug, you'd complain of bone pain at different sites in your body because it's stimulating your bone to release, not only to increase production and release of neutrophils out of the bone marrow. So nursing responsibilities, so it's administered subcutaneously. We do monitor the CBC for the white blood cell count, the leukocyte count. I don't have much to say on sickle cell disease for this. Caution in sickle cell. I think I'll just leave that. I don't think that's very important. Okay, so let's move on to the next section, which is immunizations. And in this section, there's going to be some immunization memory because of times in your life starting as an infant when you receive. So there's an immunization schedule, and there's that just takes some memory. But the understanding of how immunizations work doesn't take memory, just some understanding. So basically, we use immunizations to form an immunity, a long-lasting immunity to many diseases in the world. So the idea behind an immunization is that it produces active immunity. So we inject, some immunizations can be oral, most of them are injectable as an intramuscular injection. So we inject a certain immunization or an antigen intramuscularly, and the body sees it as foreign. Okay, so let's just use an example of, say, tetanus toxoid. So we want to make someone immune to tetanus. So we inject the toxoid, the toxin part of the tetanus, intramuscularly. Okay, the body says, ooh, I recognize this as foreign. I am going to immediately produce antibodies to attack this antigen, this tetanus toxoid, so that I can clear it from the body. Now, the first time that it sees the immunization, such as tetanus toxoid, it's going to take weeks to make the antibodies to really come up to a good level to neutralize the antigen, right? So very young infants that are unimmunized are at danger of acquiring serious infections because they haven't been immunized yet. Or for example, someone who's never had any immunizations, they're at very high risk for acquiring infections that most of us wouldn't have to deal with if we've been immunized. So active immunity is the production of antibodies that can then attack the antigens, and also memory cells. And these memory cells last for years to decades in your body. And when they see the same antigen again, they can immediately attack it. They can form antibodies very quickly, immediately attack and clear the antigen with an immediate antibody response. Okay, so there's antibody production, upon exposure to the antigen. And then there's memory cells that can quickly make antibodies years down the road when that antigen comes into your system again. Okay? So why do we give booster vaccines? That's to keep, so a booster vaccine is given, whether it's months or years later, to stimulate the immune system to remind itself that it needs to maintain high levels of memory cells and antibodies against that specific antigen. Uh, so, so that's active immunity, and that's typically what we use in with immunizations. There's also something called passive immunity, and that's basically just protecting someone with an injection of the actual antibodies um, instead of the body making the antibodies. And I'll give you an example of that. So someone who's been attacked by a wild animal such as a raccoon and has multiple bites, well, it's unlikely that on the rare chance that that animal, such as a raccoon or a bat or a fox, those are rabies carrying animals. It's unlikely that the human has any antibodies in its system to fight off the rabies virus. It's never seen it before, it doesn't have antibodies to it, and we don't vaccinate routinely for rabies unless you're in certain professions like a veterinarian. So what do we do? Well, we have antibodies in a vial that's made in a lab that we inject into you. And it gives you passive immunity, meaning it's going to wear off in a month or 6 weeks. The antibodies will break down since antibodies are just proteins. But in the meantime, what the antibodies are going to do is they're going to attack specifically the potential rabies infection or the rabies virus that's been introduced to you from all the bites. So that's passive immunity. It's basically a quick fix that can last, 2, 3, 4 months to protect you. Another example is that you're going traveling in a third world country and you've never been immunized, say, to hepatitis A or hepatitis B. Well, you can get passive immunity. It's not the greatest way to do it. It's better to have the active immunity through a hepatitis shot or vaccine, but you can have passive immunity by getting injections of the antibody that protects you from hepatitis. Okay, and that's passive immunity. So so on this slide we see a little girl getting a immunization. So immunizations, we know that there's many diseases that we can prevent with immunizations. So whether it's tetanus, diphtheria, pertussis, meningitis, hepatitis. There's many diseases we can prevent by using immunizations. And we see these diseases even more in developing countries that don't have very strong immunization schedules for children and adults. Okay, so let's just look at this schedule briefly. And I'm not going to go over the times when you get injections. That's just something for you to look at. But let's just go over the diseases quickly. So hepatitis B. So Hep B is a disease that attacks the liver, and it's hepatitis B because it's the B virus. And it can give you intense inflammation of the liver, and go on to develop chronic hepatitis. And when you have chronic hepatitis, for years and years, that can lead to cirrhosis. So it's definitely a disease that we want to prevent. Hepatitis B. Okay, there's 3 very common hepatitis viruses. Hepatitis A that we'll come to, hepatitis B that we just spoke about, and hepatitis C, for which we don't have a vaccine yet. The next one is RV, so rotavirus. So this is a somewhat new vaccine. And rotavirus is a virus that really attacks children's intestinal tracts and gives tremendous amounts of diarrhea and vomiting. So you could say, well, you know what? I mean, most people get by just fine with a bout of diarrhea and vomiting. And that would be true because prior to this vaccine, most people were still easily treated with IV fluids and sometimes even just oral fluids, getting the child through this diarrheal illness with fluid hydration. But a vaccine came out, rotavirus, to try and protect children from getting this virus and causing intense diarrhea. The next one, look, look how many shots you get from it, of it. So DTaP, diphtheria, tetanus, and acellular pertussis. So pertussis. So diphtheria, tetanus, and pertussis. Let's talk about these for a bit. So diphtheria is caused by a bacteria that typically attacks the back of your throat, causing a very, very thick covering, thick layer of infection at the back of your throat that can lead to difficulty breathing, and if severe enough, can lead to death. So it was definitely one that made children extremely ill, and some of them even died from diphtheria. Tetanus is another bacterial infection caused by a bacteria called Clostridium tetani. And it's the toxoid, it's the toxin of this bacteria that can get into your system and cause severe muscle spasms. There's another term for tetanus called lockjaw, where you have such tight muscle spasms of your jaw that you can't even open your mouth. Your back can severely arch. It's a relatively rare disease now because of look at how many vaccinations you get for it. So it's relatively rare. And on top of that, you get boosters of tetanus every 10 years later on throughout your life. So, there's tetanus. Now, what about pertussis, or the other term for pertussis is whooping cough? So this is caused by a bacteria as well, called Bordetella pertussis. I kind of like the name, so I just mention it. I don't think you need to memorize it. And this starts off as a typical, runny nose, sore throat, and then it turns into a nasty cough. And you cough and cough and cough, and we call it the 100-day illness, the 100-day cough, because you cough for months with this, and you can cough so forcefully that you have trouble getting your breath, and that's where the whooping comes in. So you cough and cough and cough and cough, and when you take a big breath in, it sounds like it's whooping. So we call it whooping cough, and that's what the child sounded like. So it's a pretty debilitating illness, and it can lead to severe fatigue from all the coughing. You can actually break ribs from all the coughing, and you can have periods where especially in children where they're just not breathing for periods of time, called apnea, uh, because of the fatigue and all the coughing they're doing. So it's a very good illness to prevent with an immunization. The next one is the Hib vaccine, Haemophilus influenza B. Um, this particular bacteria, Haemophilus, sounds like a virus, but it's not. It's a bacteria. And this caused a condition called epiglottitis. And also it could cause pneumonias as well. Epiglottitis, when you developed epiglottitis, you developed a swollen epiglottis in your throat. The epiglottis is the little flap that opens and closes. So when you swallow, it closes so no food goes into your airway, and then it opens back up, right? So it's that flap that goes over your airway. And when you got epiglottitis, it would get extremely swollen. The child couldn't swallow. They were drooling. They couldn't drink anything, and their airway could close, leading to, of course, to death. So with this vaccination, epiglottitis in childhood almost has disappeared. Not completely, but it's definitely been vastly reduced because of this vaccination. Okay, so the Hib vaccine. The pneumococcus vaccine is next. So pneumococcus 13. So this has different strains of pneumococcus in it. So that's why it's called pneumococcus 13. And there's multiple vaccinations for this one now. And what does this prevent? So pneumococcus is a very invasive bacteria. It can cause severe pneumonias and meningitis in children. So they receive protection for pneumonias and meningitis with this vaccine. Okay, so the next one is IPV, inactivated poliovirus. And look when it's given. It's given when you get your DTaP. Right? Remember, a lot of these vaccines, they don't want you coming back. They don't want to depend on someone coming back every second week for another vaccine. So they're trying to group them together. So if you look at DTaP, Hib, IPV, pneumococcus, they're given at very similar times, right? And so this is to prevent polio, which is a paralyzing disease of the spinal cord. And there was really no treatment for this particular virus called poliomyelitis. So myelitis is just referring to the spinal cord, polio to the infection. So when you got polio, you'd be left with some kind of spinal cord disability. Often it would be paralysis to your lower limbs. The next one is the influenza vaccine, the flu shot. And we'll get into details about that. MMR is mumps, measles, and rubella. So mumps is a viral infection that attacks your salivary glands, your parotid gland, and as well, and another big issue of this is it can cause orchitis, which is inflammation of the testicles. And also it can cause inflammation of the ovaries and damage to those organs. So it can result in infertility. The virus of mumps can also go to the brain and cause meningitis. It can lead to deafness. So it's definitely a virus to try and avoid. And if you've ever seen pictures of some of the mumps, they usually have huge facial swelling on each side from the inflammation of the parotid gland. Measles is another viral illness. It usually starts with a fever, sore throat, very red eyes. that then you followed by a development of a diffuse rash on the body. Typically starts on the face and then spreads downwards from the face. It gives extremely high fevers. There's a couple of classic, maybe it's worth knowing this term for the future. There's something that's diagnostic for measles. It's called Koplik spots with a K, and these are little white spots within the mouth of the child. When we look at the sides of their inner cheek, we can see these white spots called Koplik spots. The big thing with with measles is that it can not only lead to a pneumonia, a viral pneumonia, but measles can lead to encephalitis, which is inflammation of the brain from the virus. And of course, not only can this be deadly, but if it isn't deadly, it is still very serious, since it can cause seizures and blindness as well. So think of it as a viral infection, high fevers, diffuse body rash starting from the face and going downwards, Koplik spots in the mouth, very, very red eyes. It can be complicated by pneumonia and encephalitis, which is inflammation of the brain. Varicella is chicken pox, so that's a viral infection that we now can prevent with the varicella vaccine, so that children don't have to get chicken pox, and as well it prevents shingles or herpes zoster later in life, and we'll get to that. We'll talk about that a bit later. So that's the varicella vaccine. And the Hep A vaccine, so that's to immunize against hepatitis A. That's the mildest form of hepatitis. It never goes on to cause a chronic disease, a chronic hepatitis. You almost always clear it yourself. But we have a vaccine for it now, so that if you were to acquire hepatitis A, and typically you acquire it from dirty water, traveling in a developed country, dirty food, unsanitary conditions. If you were to get hepatitis A, you would still likely clear it yourself, but you'd be sick for weeks. So hepatitis A vaccine protects you from this particular disease.
Okay, so let's look at some common contraindications to vaccinations. So some of these are pretty straightforward. An anaphylactic reaction to a vaccination, to say the viral or the bacterial component of the vaccine. That would be a reason not to receive it again. Or an anaphylactic reaction to any component of the vaccine, because vaccines are made of the antigen that's going to stimulate the immune response in the patient, but also it has other components in it. For example, some of them can have some trace egg components, since it was grown in an egg solution. Some of them can have gelatin where the vaccine was grown. So it just depends which vaccine we're talking about. Live vaccines are usually completely avoided in anyone who's immunocompromised. So that would be patients with cancer, receiving chemotherapy. But don't forget, that would also include someone who is pregnant. And not to say that someone who is pregnant is ill, but they are relatively immunocompromised compared to not being pregnant. So we avoid live vaccines in pregnancy. Severe febrile illnesses. So if a child is suffering from a severe febrile illness, we'll typically avoid the vaccine until they are better. Moderate or severe, which is the bottom one. Now, if they come in with a mild illness, maybe a runny nose, maybe some mild cold symptoms, it's more important to administer the vaccine than to delay it to another month. So mild symptoms is not a reason not to receive the vaccine. So we've reviewed this before. What does the vaccine do? What's the action? Well, the vaccine is an antigen. It's foreign to the body, and it stimulates the immune system to produce antibodies and memory cells to provide active immunity against that infection in the future. What's the therapeutic use? Well, if we're talking about population-based diseases, it would be to completely eliminate the infectious disease in the population, and also to prevent the infectious disease in the individual. This is very difficult to do since some people aren't vaccinated. So there's often sporadic outbreaks of infections where most of the population have been immunized. An example would be measles. There are sporadic measles outbreaks in the United States and Canada. It's not always possible to completely eradicate the infectious disease. Okay, so let's look at the first vaccine here. It's a combination of three. It's called DTaP. So it's diphtheria, tetanus, and pertussis. This is an inactivated vaccine. So when something's inactivated, it means there's nothing live in it, or even live attenuated, meaning it's a live vaccine, but it's been adjusted in some way that it can never cause the illness when injected. But this is inactivated. So usually inactivated vaccines means that the units have been chopped up, have been cut up, and then put into the vaccine to be injected. So you can see this vaccine is given in very frequently in early childhood, and then a booster at 4 to 6 years. The adverse effects, the first ones there, the mild ones, they're common to almost every vaccine. Redness at the injection site, a bit of swelling, a bit of tenderness, maybe some low-grade fevers. They're quite common. But let's look at the less common ones, and they're under precautions. Development of some kind of seizures, or look at the other one, temperature of above 40.6 after the vaccination, seizures, inconsolable crying. So that's crying that goes on for hours and hours and hours after the vaccination. So think of those more severe side effects to the vaccine as opposed to common mild ones. Another condition that has been associated with vaccines, but it's extremely rare, is a condition called Guillain-Barré syndrome, which is a neurological demyelinating condition where the sheath surrounding your peripheral nervous system is affected, and and destroyed. And this has a very, very weak association with vaccines. But if someone has a history of Guillain-Barré, or they develop Guillain-Barré following a vaccination, which is, again, extremely rare, that would be a reason not to proceed with further vaccinations of this type. Okay, so this next slide is again tetanus, diphtheria, and pertussis. And you might be wondering, well, what's the difference between this one and the slide before? The letters have just been turned around. Well, this is more of a booster shot for later in life. It still has the same 3 components in it, but this is more of a booster. So it has a capital T because the amount of tetanus vaccine is the same. But the diphtheria and the pertussis have been reduced in the amount of in the concentration that they've been added to the vaccine. So you don't typically need as much diphtheria and pertussis vaccination after your childhood series, since you've had so many of them. You're basically immune to those illnesses. So this is a booster shot at 11 to 12 years of age. And as well a booster shot in a pregnant woman between 27 and 36 weeks pregnant. So, and then typically after you've had a Tdap, you're going to get TD shots every 10 years. So tetanus diphtheria shot every 10 years. So it's not like you get a Tdap every 10 years. So you get your booster at around 11 to 12 years. And then if you become pregnant, you get a Tdap. And then every 10 years after that, you'll get a TD shot. And the adverse effects, they're pretty minimal with this vaccine. Precautions, again, if someone has a history of encephalitis, which is inflammation of the brain following a vaccination, that would be very rare, or a history of Guillain-Barré syndrome that has been associated with vaccines in the past in that patient. That would be a reason not to give this vaccine. Tetanus diphtheria booster. So this is the booster that you're going to receive every 10 years to remind your immune system to keep tetanus immunity and diphtheria, but in particular tetanus immunity at a high level. Okay, so you had Tdap as a child. You had Tdap as a booster at around 11 to 12. You get Tdap when you're pregnant, but you get TD as your ongoing booster every 10 years. Now, if you have some kind of an injury that is tetanus prone, like say for example, you cut yourself with a chainsaw and it's a deep wound, because tetanus is usually happens in a deep wound, or you have a deep puncture from a nail, then typically you'll get a booster at the 5-year point. So even though you were routinely getting it every 10 years just as a booster, if you have an injury that's tetanus prone, then typically you'll get one after 5 years. Okay, so Haemophilus influenza vaccine, so the Hib vaccine. So remember, this was to vaccinate children against epiglottitis, and as well, Haemophilus can cause a pneumonia in children. So this essentially eliminated epiglottitis in childhood. There's very little reason not to get this vaccine. You can see under contraindications, there's not much there. Precautions, we left it blank. Sure, you can get some redness and swelling and warmth at the injection site, but overall, this is a very well-tolerated vaccine. Okay, so rotavirus is a live attenuated vaccine. So remember, we don't give live attenuated vaccines to immunosuppressed people or pregnant women. This vaccine is to prevent a viral illness that can cause profuse diarrhea and vomiting in young children. I won't go over the schedule for giving it, but remember, so a live attenuated vaccine can give you a similar side effects to the actual disease itself, but in a very, very mild form. So mild diarrhea and vomiting. Intussusception is a form of bowel obstruction that children can sometimes get, and it's where the bowel telescopes within itself, and then an obstruction occurs. We'll get into detail in that in a different module. So what would be the contraindications to giving this vaccine? Well, intussusception, which is that bowel obstruction, and then of course any kind of immunodeficient illness or condition. What precautions? So if someone has some kind of a gastrointestinal disease or they're immunocompromised, I'm not going to get into spina bifida or bladder exostrophy. I don't think that's necessary. But if someone has some kind of chronic gastrointestinal disease or they're immunocompromised, that'll be a reason to avoid this vaccine or to discuss it with the parents, the pluses and minuses of receiving this vaccine. So the next vaccine, you can really think of this vaccine as added to DTaP on the schedule, because really this is when you get this, right? 2, 4, 6, and around 18 months plus a booster at 4 to 6 years. So it's often combined with DTaP. So this is to prevent poliomyelitis, which can lead to paralysis from a spinal cord viral infection from polio. Very well tolerated. Tenderness at the injection site. Contraindications, reasons to avoid it. I'm going to tell you this would be extremely rare to avoid this vaccine. I mean, if you had an anaphylactic reaction to some component that was within the vaccine, such as so neomycin, streptomycin, or polymyxin are antibiotics, and there are trace amounts of these within the vaccine. So if you had an anaphylactic reaction to these, it would be a reason to avoid receiving it. And as a precaution, it would be pregnancy, but this is not a live vaccine, so it's not a contraindication. But remember those odd contraindications, such as these. Okay, the mumps, measles, rubella vaccine, MMR. So this is usually given at around a year, and then a booster at 4 to 6 years. This is a live vaccine, right? A live attenuated vaccine. So what can happen with live attenuated vaccines? You can get a mild illness that mimics the actual disease that you're trying to prevent. So you can get rashes because measles gives you the rash. You can get fevers. You can get swollen glands in your cheeks or your neck. You can get joint pain and ongoing fevers that can last for weeks. You can also get a low platelet count because that can occur with these illnesses such as measles. So live attenuated can give you a very, very mild form of the actual disease. This vaccine is contraindicated in pregnancy, no problem in breastfeeding. So if you became pregnant and you didn't, and it was noticed that you haven't had an MMR, you would receive it after the pregnancy, not during the pregnancy. Precautions: if someone has a history of thrombocytopenia, low platelets, it wouldn't be a reason not to receive it, but it would be a reason to be aware that this is something we should keep an eye on because they already have low platelets. Definitely anaphylactic reactions. So look at the anaphylactic reactions to eggs, gelatin, and neomycin. These can be in small amounts within the vaccination. So if you have anaphylactic reactions to them, then that would be a reason to avoid this vaccine. Varicella vaccine, so the chickenpox vaccine, another live attenuated vaccine. Remember, live attenuated vaccines produce a much longer immunity. The body is seeing these as a potential threat because they're live attenuated, meaning they've been turned down in the laboratory. Compared to other vaccines like subunit vaccines where the virus or the components have been chopped up, so they're not as much of a threat. So live attenuated are produce a very long-lasting vaccine, and you often don't have to give as many shots because the immunity to each vaccination, it produces a very strong immune response. So this is typically given in two separate shots. The adverse effects are pretty mild. You can develop seizures. Varicella is a virus. So in a live attenuated vaccine, there's a possibility of causing seizures. It would be extremely unlikely. Contraindications, so pregnancy, we don't give live attenuated vaccines to pregnancy. And again, while patients on chemotherapy, they're immunosuppressed. Anaphylactic reactions to gelatin or neomycin. So these are just components of the vaccine when the vaccine was produced. Precautions: any antiviral medications that were used for some other reason within 24 hours of receiving the vaccine or for 2 weeks after the vaccine. Well, if you're giving a viral vaccine like chickenpox vaccine, you don't want someone to be on antivirals because it'll weaken the immune response theoretically to the vaccine. All right, so if you're on an antiviral and then you're taking a viral vaccine, the antiviral medication is going to weaken the body's response to it. So no antiviral medications. Or anything else that can weaken the immune response to it. So for example, steroids. Well, we already mentioned that steroids reduce the immune response. They lower they weaken your immune system while you're taking them. So you won't get as strong of a immunologic response to the vaccine if you're on corticosteroids. So that would be a reason um, to avoid the vaccine until you're off the corticosteroids. Okay, so pneumococcal conjugate vaccine, PCV13. So the schedule very similar to other childhood vaccination schedules. Remember, you want people to be compliant with their vaccination schedules, so vaccines are grouped together for when children come in, as opposed to having them come in every month. This is a very well tolerated vaccine. It's to prevent pneumococcal bacterial disease. So that would include sepsis, so bacteria that's invaded the bloodstream of the child and is causing sepsis, pneumonia. So pneumococcal pneumonia can be very serious. And then, of course, pneumococcal meningitis, where the bacteria gets into the layers of the brain, meningitis. Okay, hepatitis A, okay, inactivated vaccine. So that's basically telling you almost anyone can receive it, although we do avoid vaccines in pregnancy in general. There's typically 2 doses to the vaccine. Adverse effects are minimal. Contraindications. So here's one of these strange contraindications. So try to remember strange things because they kind of stand out, right? So everything else makes sense, and then you come to the contraindications. It says severe allergy to latex related to the packaging. Well, I consider that a strange contraindication, so I would try and recall that one. And remember, hepatitis A is the hepatitis that you get from dirty water, dirty food, unsanitary conditions. And you ingest it, you eat it, and then you develop a self-limiting hepatitis. So hepatitis A resolves by itself. Now, you do get ill with it, but it doesn't become a chronic hepatitis like B or C. Okay, so hepatitis B vaccination, typically given in 3 separate shots. Adverse effects are minimal. Yeah, some tenderness at the injection site, maybe some low-grade fevers. Remember, this is not a live vaccine, so can basically be given to almost anyone. Contraindication. So here's another strange one. This anaphylactic allergy to yeast components or yeast. So it's been grown in yeast. If you have an allergy, some severe allergy to yeast, then that would be a reason not to receive the hepatitis B vaccine. So remember, children get hepatitis B vaccinations so that they're immune to Hep B. And Hep B is one of the one of the hepatitis, one of the liver infections from like a viral hepatitis that can lead to a chronic state of always having the virus in your liver and gradually destroying the liver, then leading to cirrhosis, which is end-stage liver disease. So how do we get hepatitis B? It's typically through IV drug use, sexual activity with someone else with someone who has hepatitis B. It's not usually like Hep A, which is through contaminated water or food. Hep B was also an infection that you could acquire through blood transfusions. It is still possible now, but much less frequent to get an infectious disease through a blood transfusion because of all the screening that the blood goes through prior to being administered to a patient. Okay, so the flu vaccine, influenza. So there's different types of influenza vaccines. So typically, you can start receiving it at the age of 6 months. And this is an annual vaccine, right? Because influenza, the strains change every year. So we try to predict which strains are coming through, whether it's in North America or whichever country you live in. And then a vaccine is made annually to try and treat those strains. So until the age of 2 years, you're receiving an inactivated influenza vaccine. And then after the age of 2 years, you can receive a live attenuated vaccine. And remember, live attenuated gives you more immunity typically. So, so you want to use the live attenuated vaccine if it's available. The adverse effects we won't go into. Those are all very common adverse effects. Contraindications, well, Guillain-Barré syndrome is that one that if you have a history of it, I think we'd think of not giving a vaccine or reconsidering the vaccine with anyone who has a history of Guillain-Barré syndrome. Precautions. So years ago, if you had an egg allergy, you couldn't receive the flu vaccine because it was produced in eggs. Now there's many different types of influenza vaccines, and some aren't produced in eggs. So you can receive an influenza vaccine that's just not produced in eggs. So patients with egg allergies should still or can still receive the immunization. If there was a previous reaction, then that's where a healthcare provider can observe the patient. We typically, if you're giving vaccines, wherever you're giving vaccines, you typically have treatment in case someone goes into anaphylaxis for any vaccine. So typically you need to have epinephrine available as the treatment for someone who develops an anaphylactic reaction to a vaccine. Meningococcal vaccine is not a live vaccine, subunit vaccine, so chopped up into pieces. This is given between the ages of 11 and 12 and a booster at 16. So why do we give? So meningococcus is a type of bacteria, by the way. And meningitis is the disease that it can cause. Not a very common disease, but a severe disease and a deadly disease. So this vaccine came out to try and prevent meningitis, even though it is a relatively rare disease to acquire. And if you are going to acquire meningococcal vaccine or meningococcal disease, it was typically in crowded conditions, dormitories, military dormitories, school dormitories. So the vaccination is given at 11 to 12 years and then a booster at 16. It doesn't prevent all meningitis. Adverse effects, minimal. Contraindications, precautions, we left intentionally blank. I don't think it was extra detail that you needed. Okay, so human papillomavirus, HPV. This is a relatively new vaccine. It's only been out in the past, probably since 2010, maybe probably earlier than that, 2005. It was a bit of a controversial vaccine. What are we trying to prevent with HPV? Well, we're trying to prevent cervical cancer in women, warts. Okay, so we know that cervical cancer, a lot of them are caused by a virus, by the human papillomavirus, that causes mutations in the cervical cells that leads to cervical cancer. Human papillomavirus can also give you anal warts, so warts externally on the anus. It can give you genital warts on the penis or externally in women as well. So it was to prevent all those, but the most important was to prevent cervical cancer. Adverse effects, nothing overly exciting there. Contraindications, well, pregnancy, most we're not going to give them in pregnancy. And typically you're trying to get this vaccine in before someone actually gets human papillomavirus, because then there's very little evidence that it's effective, right? So you don't want to be giving a 30 or a 40-year-old HPV vaccine because they have possibly already acquired HPV. Okay, so it's 11 to 12 years of age, and then a repeat shot. So remember that the most common cause of cervical cancer is human papillomavirus. Now, this also got the indication for boys in many places. And why would it get the indication as a vaccination in boys? Well, in girls it made sense to prevent cervical cancer, although we'd have a very good screening test for cervical cancer in women called the Pap test. So that's why it was a bit of a debatable vaccine. But in boys, it was to prevent genital warts and penile warts, which could then be passed on to women. So in many places, this vaccine has been given the green light for administration to boys as well. Okay, so here's just some vaccines that an adult who is immunocompromised from any kind of immunocompromising disease can receive. So a pneumococcal vaccine called Pneumovax. This is to prevent pneumococcal pneumonia later in life. So an older adult or an adult that has a condition that's causing them to be immunocompromised can receive pneumococcal vaccine. Meningococcal vaccine can also be offered. Again, this is to prevent meningitis. And then lastly, the herpes zoster vaccine can be offered to anyone who's immunocompromised, or basically to anyone who wants it, to try and prevent an outbreak of shingles or herpes zoster from occurring. Okay, so let's talk about immunoglobulins, which is basically going to be a conversation about passive immunity. So providing immediate immunity to someone who doesn't have the immunity to a certain disease. So immunoglobulins are antibodies. So they can be infused or injected, an IM injection of antibodies, giving immediate protection to someone with a potential disease state. So often when you're giving someone passive immunity with antibodies, you're also giving them the active immunization so that they have long-term immunization. So we'll come to an example. So let's come to the different conditions. So CMV, cytomegalovirus, we won't discuss that one. I don't think that's necessary. Let's go to hepatitis B. So someone who say hasn't been vaccinated to hepatitis B receives or gets a deep needle stick injury, and it's deemed that the needle stick injury has been from someone who is Hep B positive. Well, how can we treat this person that now has a deep needle stick injury? Well, we can give them passive immunity with immunoglobulins, and we can also start the active immunity with immunization to Hep B. So they're getting passive and active immunity. The same would go for rabies. So someone who's bitten by a raccoon or a bat or a fox or a stray dog, and they have multiple bite wounds, they need passive immunity, meaning immediate antibody immunity. So we can give that as an injection. And also we want to provide long-lasting immunity because the passive immunity is going to wear off pretty fast. So they'll also receive the rabies vaccine. An example of passive immunity by itself would be the RhoGAM shot that's given to pregnant women that are Rh negative. So we give RhoGAM because there's always a bit of mixing of the fetal and maternal blood. And if the mother is Rh negative, we typically just assume that the fetus is Rh positive because most people are Rh positive. And without testing the father, and we just assume that the fetus is Rh positive. So if we get a mother that's Rh negative, then she qualifies for the RhoGAM shot, which is basically an antibody to the Rh factor. So if there's any Rh factor floating in her bloodstream that's leaked from the fetal circulation, it will be bound up by the RhoGAM shot as passive immunity, so that the mother's immune system doesn't produce antibodies against Rh. And why do you want to do that? Because in future pregnancies, if the mother made Rh antibodies, it could attack the fetus's blood, since the fetus is likely Rh positive. So it's trying to prevent miscarriages and maternal antibody destruction of fetal red blood cells. Okay, so that's a passive. RhoGAM is just an antibody shot against the Rh factor, on the chance that there's circulating Rh red blood cells from the fetus in the maternal circulation. Tetanus. So if someone comes in and they've never had a tetanus shot, and they have a deep open wound from some kind of an injury, like they fell off a farming machine into dirty soil, we'll make it as clear as possible, and they don't have any immunity to tetanus. So they'll be offered tetanus shots to start developing active immunity, but that's going to be weeks before that becomes effective. So they will also be offered passive immunity with immunoglobulins to immediately protect them from getting tetanus. So hopefully that gives you a good idea of what immunoglobulins which really are just antibodies to provide passive immunity, are used for. Okay, so here's RhoGAM. Let's talk about it a bit more. So it prevents isoimmunization in pregnant Rh negative women, prevents hemolytic anemia of the newborn in the second trimester. So the first thing it does is it prevents the pregnant woman from making antibodies to the Rh factor. So if the fetus is, so the fetus and the mother shares blood a bit. So if the fetus is giving the mother some Rh positive blood, then the mother is going to produce, the Rh negative mother is going to produce antibodies against this Rh factor, which isn't going to be an issue in the first pregnancy. In the second pregnancy, what's going to happen is those antibodies have already been produced by the mother in the first pregnancy. And in the second pregnancy, those antibodies are going to recognize that Rh factor in the fetus and attack the red blood cells and cause destruction of those red blood cells in the newborn, or as the infant is being born. So it can cause a hemolytic anemia. So we try and prevent that by giving RhoGAM shots to Rh negative pregnant women. So how does it work? It combines with the Rh factor that is from the fetus and circulating a bit in the maternal circulation. It neutralizes the Rh factor, so the antibody combines with the antigen and gets rid of it instead of the mother producing antibodies to the Rh factor. Adverse effects, well, those are basically to almost any, if you're giving an injection of an antibody or any foreign substance, you can get, fevers, chills, aches. Contraindications. So Rh negative fetus, well, there would be no reason to give RhoGAM, which is just the antibody to the Rh factor. So if you know for sure that you have an Rh negative fetus, but we usually don't know that, since we don't know the Rh status of the father. So we assume that the fetus is Rh positive, since about 85% of us are Rh positive. And the other reason not to give it is if you have an Rh positive mother. Well, then she doesn't need RhoGAM because she's not going to make antibodies against the Rh factor since she's already Rh positive. So it's for an Rh negative mother. During pregnancy, she will get a RhoGAM shot at around 28 weeks as a prevention to avoid producing antibodies to the Rh factor. And as well, if during pregnancy there's bleeding, there's vaginal bleeding, well, that's potential for the blood to mix with, like the fetal blood to mix with the maternal blood. And we'll sometimes give a RhoGAM shot for vaginal bleeding during pregnancy. Okay. As well, postpartum, they will receive a preventative dose of RhoGAM, again, to avoid producing antibodies to the Rh factor. So 28 weeks gestation and postpartum. Remember, this is an antibody, it's a blood product, so the patient needs to sign a waiver that they are receiving a blood product.